Good morning everyone. Today I am presenting seminar on CSF changes in various disorders of brain. Cerebrospinal fluid, it is a clear colorless fluid and formed in ventricles of brain, mainly choroid plexus. It is mainly an ultrafiltrative plasma contained within the cerebral ventricles and spinal canal and subarachnoid space. It is absorbed into blood through arachnoid villi of dural venous sinuses. Composition: total volume includes 100 to 150 ml, opening pressure 60 to 180 mm of water. Appearance: usually it is clear and colorless with no clot. Cells: in adults it contains 0 to 5 cells per cubic mm, in infants 0 to 30, 1 to 4 year 0 to 20 cells, and 5 to 18 years 0 to 10 cells per cubic mm. Normal glucose is 45 to 80 milligram per deciliter. Proteins 15 to 45 milligram per deciliter. Usually oligoclonal bands are negative and chloride is 120 to 130 milliequivalent per liter and bilirubin is absent. Functions: protection of brain and spinal cord from injury by acting as a shock absorber, and it serves as medium between blood and brain for supply of nutrients to and remove of waste products from the brain. Coming to the collection of CSF fluid, some diseases produce characteristic alteration in composition of CSF, thus providing the basis of examination of CSF. Lumbar puncture, it is a procedure whereby sample is obtained. Spinal or LP needle is passed between third and fourth or between fourth and fifth lumbar vertebra, and CSF is obtained from the subarachnoid space. With the three-wave stopcock in a appropriate position, CSF is collected in sterile plain tubes as follows. Tube 1 for chemistry, that is for glucose and protein estimation and for serology. Tube 2 is for microbiology like gram staining, bacterial culture and sensitivity. Tube 3 for hematology like total count and differential count. And tube 4 is for cytology and special studies. Typically 3 to 5 ml of CSF is collected, and after CSF collection the closing pressure is recorded. Coming to indications of lumbar puncture, first one is for examination of CSF for diagnosis in suspected cases of CNS infections like meningitis and encephalitis, and meningeal involvement by leukemia or malignancy, in subarachnoid hemorrhage, and in some inflammatory diseases like multiple sclerosis, and for diagnostic of gamma globulin findings, and in Guillain-Barré syndrome, and some neoplasms of central nervous system. Second one is to reduce CSF pressure in benign intracranial hypertension cases. And third one is for administration of medications like anesthetic agents, antibiotics, anti-cancer drugs, introduction of radiographic contrast media for the myelography. And fifth one is for the Queckenstein's test. If opening CSF pressure is normal and clinically subarachnoid block or a tumor or a sinus thrombosis suspected, then this test may be performed. Complications of lumbar puncture include post-puncture headache, introduction of infection in the spinal canal, subdural hematoma, failure to obtain CSF, herniation of brain, subarachnoid epidermal cyst. Contraindications include raised intracranial pressure, cardiorespiratory compromise, bleeding diathesis, local infection at the site of lumbar puncture. These are some recommended CSF laboratories routinely used. Are opening CSF pressure measurement, total cell count, differential count, glucose and protein. And some useful under certain conditions include cultures for the bacteria, fungal viruses and etc. For gram stain, acid fast stain, and fungal and bacterial antigens. For cytology, VADRL test for syphilis and Diseases detected by laboratory examination of CSF include it is high sensitivity and high specificity in cases of bacterial, tuberculous, viral, and fungal meningitis. Highly sensitivity and moderate specificity in cases like subarachnoid hemorrhage, multiple sclerosis, CNS syphilis, infectious polyneuritis, and moderate sensitivity and high specificity like in meningeal malignancies. Moderate sensitivity with moderate specificity in intracranial hemorrhage and subdural hematoma. Laboratory examination of cerebrospinal fluid. After collection, specimen of CSF should be transported immediately to the laboratory and examined without delay. This is because cells disintegrate rapidly and reduction of glucose level occurs due to glycolysis. CSF should be examined within 1 hour of collection, and CSF cell counts are always done within 30 to 60 minutes of collection. Glass tubes should not be used for the collections since cell adherence to glass reduces the cell count. The specimen for bacterial culture should not be refrigerated as fastidious organisms like H. influenza, Neisseria meningitis do not survive in the cold temperature. For chemical examination, results should be always compared with those in the plasma since any change in plasma is reflected in the CSF. Examination of CSF includes opening pressure, appearance, total and differential count, chemical examination, microbiological examination, and special investigations. Coming to opening pressure, after attaching the manometer to the hub of the spinal needle, patient's legs should gently extended and neck returned to neutral position. The CSF pressure is then measured. Normal opening pressure of CSF is 60 to 80 mm of water in adults in lateral recommend position. 10 to 100 mm of water in children less than 80 years. Coming to causes of increased CSF pressure, it is seen in TENS and AXIS patient and in intracranial mass lesions like neoplasm, abscess, and hemorrhage. Also seen in meningitis, cerebral edema, subarachnoid hemorrhage, congestive cardiac failure, benign intracranial hypertension. Decreased pressure seen in leakage of spinal fluid following trauma or previous lumbar puncture and complete spinal block like in cases of tumors, abscess, adhesions, herniated intervertebral disc. A large difference between opening and closing pressures usually indicates presence of a partial or complete spinal block. If opening CSF pressure is more than 200 mm, then no more than 12 ml of the CSF should be removed. Coming to gross appearance, normally it is clear and colorless like distilled water and there are no clot formations. The abnormal CSF may appear turbid, blood mixed, xanthochromic or viscous. The clot formation in the CSF is abnormal and it indicates increased proteins. So turbid CSF seen in leukocytes more than 200 cells per cubic mm. If there are red cells more than 400 cells per cubic mm and in microorganisms like bacteria, fungi, amoeba and aspiration of if there is aspiration of epidural fat during a lumbar puncture and if there is raised protein levels. Blood mixed CSF is seen as a result of traumatic tap or in subarachnoid hemorrhage. The distinction of traumatic tap from the subarachnoid hemorrhage is very important. So, in this table, we can see the difference between traumatic puncture and actual subarachnoid hemorrhage. In traumatic lumbar puncture, crossly it is more blood in initial tubes compared to the later tubes and there is no blood there is formation of blood clot on standing. But in subarachnoid hemorrhage, the blood is uniform in all 4 tubes and blood does not clot on standing. The supernatant is usually clear in traumatic lumbar puncture, but it is pink or yellow in subarachnoid hemorrhage. On microscopy, there is a progressive decrease of red cells count in later tubes. Compared to subarachnoid hemorrhage, the RBCs are uniform in all the tubes, and we can also see hemosiderin-laden macrophages. On latex agglutination test, it is negative in traumatic puncture while it is positive in subarachnoid hemorrhage. And cerebral spinal fluid pressure and cerebrospinal proteins are normal in traumatic puncture, whereas these two are increased in subarachnoid hemorrhage. Coming to xanthochromia, it refers to yellow discoloration of the CSF. For its detection, CSF is centrifuged and the supernatant is compared with another tube of same size which is filled with distilled water. Mainly it is seen in subarachnoid hemorrhage. These are some color changes in the CSF and associated disorders. Pink color is seen in RBC lysis, yellow color is seen in RBC lysis and hyperbilirubinemia and increased CSF proteins, that is more than 150 mg per deciliter. Orange color is seen in RBC lysis and hypervitaminosis A. Yellow green color is seen in hyperbilirubinemia and brown color is seen in meningeal metastatic melanoma. Coming to clot formation, which is also known as pellicle, this is a thin membrane or scum on the surface of the CSF. It indicates increased protein levels, that is more than 150 mg per deciliter. It is usually occurs in tuberculous meningitis, like fine cobweb-like clot after 12 to 24 hours, and purulent meningitis, spinal block, and traumatic lumbar puncture. The clot formation does not occur in subarachnoid hemorrhage. Thick viscous CSF, it is seen in cryptococcal meningitis, meningeal metastatic mucinous adenocarcinoma, severe meningitis, and release of nucleus pulpus fluid in CSF due to needle injury to the intervertebral disc. Coming to cell counts in CSF fluid, total leukocytic count. The cell count on CSF is done manually on undiluted sample in a counting chamber. Total leukocytic count increases in various disorders, and along with the differential count, it provides important diagnostic information. So the increase in cell count in the CSF, it is called as pleocytosis. It is essential to do microscopic examination of CSF for all the samples, since WBC count up to 200 per cubic mm and red cell up to 400 are associated with clear appearance of the CSF. So for correct results, the cell count should be done as soon as possible after the collection of CSF because these cellular cells are disintegrated rapidly, and these cells also adhere to the walls of the glass tubes. Methods: the CSF sample should be properly mixed. If CSF is clear, it is not diluted. If the CSF appears cloudy or turbid, 1:20 dilution is made using 0.05 ml of CSF and 0.95 ml of the Turk solution. The counting chamber is covered with a cover slip provided, and the counting chamber is filled with fluid and allowed to stand for 2 minutes for the cell to settle. For counting cells in CSF, the Fuchs-Rosenthal counting chamber is preferred because its depth is twice that of the improved Neubauer chamber. In these cells are counted in 5 large squares. If the undiluted CSF is used, then total number of cells are counted in 5 square, represents total count per cubic mm of CSF. If CSF is diluted, then this multiplied number is this number is multiplied by the dilution factor, that is 20. Causes of increased cells in CSF, it includes meningitis and other infections, intracranial hemorrhage, meningeal infiltration by the malignancy, repeated lumbar punctures, and injection of the foreign substances like radiographic contrast media drugs in the subarachnoid spaces, and also see multiple sclerosis. These are the normal percentage of the different cells in the CSF. So mostly 62% of lymphocytes seen in CSF, followed by monocytes which accounts 36%, followed by neutrophils, and rarely histiocytes and ependymal cells and eosinophils are seen. In this microphotograph, we can appreciate lymphocytes and monocytes in the CSF fluid. In this microphotograph, we can see cluster of blast-like cells in the CSF fluid. Coming to differential leukocytic count, if CSF contains only few cells, then it is centrifuged at a high speed, that is 3000 for 10 minutes, and a smear is made from the sediment. If CSF contains many cells, then the smear is made directly from the uncentrifuged sample. After staining with Romanowsky stain, smear is examined under the microscope. In normal adults, differential count shows 70% of lymphocytes and 30% monocyte. If young children, the higher proportion of monocytes are present. In this table, we can see causes of increased in neutrophils in the CSF, mainly meningitis like bacterial, early viral and early tubercular, early mycotic meningitis, and other infectious causes like cerebral abscess, subdural empyema, and following seizures and following CNS infarcts like reaction to the repeated lumbar puncture, injection of foreign material and metastatic tumor in contact with CSF. In the first table, we can see causes of eosinophilic pleocytosis. It is mainly seen in acute pyelonephritis, CNS reaction to the foreign material like drugs and shunts, fungal infections, idiopathic eosinophilic meningitis, parasitic infections, and infrequently seen in bacterial meningitis, some leukemia and lymphomas, neurosarcoidosis, primary brain tumors. Increased in lymphocytic count in CSF is seen in viral meningitis, tubercular meningitis, fungal meningitis, leptospiral meningitis, and some degenerative disorders like subacute sclerosing panencephalitis, multiple sclerosis, Guillain-Barré syndrome, acute disseminated encephalomyelitis, and some inflammatory disorders like Handel syndrome, sarcoidosis, polynephritis. In this table, we can see causes of increased in plasmacytes in the CSF, that is in acute viral infection, Guillain-Barré syndrome, multiple sclerosis, sarcoidosis, tuberculous meningitis. These are some photographs where you can see increased leukocytes. In first picture, there is many neutrophils in the CSF seen in bacterial meningitis. Second picture showing increased lymphocytes which is so normally present. Third picture showing small lymphocytes that is seen in traumatic tap. Fourth picture we can see monocytes. In the fifth we can see neutrophils and lymphocytes both in the CSF. In the sixth picture we can see these are PI and arachnoid cells which are normally lining the meningium, which is seen in the CSF fluid. And in the seventh picture we can see blast cells in the CSF. In the eighth photograph there is a malignant cell with high insertion prominent nucleoli in the CSF. This is the table depicting difference between the different infections of the CSF. So prominent neutrophils seen in meningitis like bacteria, early viral, fungal, early tubercular, subarachnoid hemorrhage, repeated lumbar puncture, and introduction of the anti-cancer drug and meningeal metastasis, and predominant lymphocytes seen in viral and tubercular meningitis and cysticercosis, toxoplasmosis, multiple sclerosis, and subacute sclerosing panencephalitis. Mixed cell pattern like neutrophil, lymphocytes, and monocytes is seen in tuberculous meningitis, fungal meningitis, chronic bacterial meningitis, and prominent eosinophils are seen in parasitic and fungal infections and reaction to the foreign body. Coming to other cells, apart from mature blood cells, CSF may contain immature hematopoietic cell tissue cells like ependymal cells, P. arachnoid, mesothelial cells, and malignant cells. CSF examination is commonly carried out in acute lymphoblastic leukemia to detect involvement of the CNS. The increased WBC count with the lymphoblast is evidence of the CNS involvement. Coming to chemical examination of the CSF, the routine chemical examination it consists of estimation of the proteins and glucose. The CSF from tube 1 is used for the chemical examination. The estimation of protein in the CSF. Normal protein levels is 15 to 45 mg per deciliter. Increase in CSF protein, it is a sensitive but not specific indicator of the CNS disease. So, CSF proteins may be normal during early stage of meningitis. Significant elevation occurs in bacterial meningitis. So, some protein levels and associated disorders. So, alpha-2 macroglobulins are associated with subdural hemorrhage and bacterial meningitis. Increase in beta amyloid and tau proteins are seen in the Alzheimer's disease. Beta-2 microglobulin, it is seen in leukemia or lymphomas and Behçet's syndrome. C-reactive proteins are elevated in bacterial and viral meningitis. Fibronectin levels are increased in lymphoblastic leukemia, AIDS and meningitis. Methemoglobin is seen in mild subarachnoid and subdural hemorrhages. Myelin basic protein, it is elevated in multiple sclerosis and other tumors. Transferrin is elevated in CSF leakage, that is otorrhea and rhinorrhea cases. Turbidimetric method, it is using trichloroacetic acid for the preparation of the protein is more commonly used. In principle, the trichloroacetic acid, when added to the CSF, it causes precipitation of the proteins and turbid solution is obtained. The amount of turbidity is compared with the turbidity of known, that is standard concentration of protein in a photoelectric colorimeter. If facilities for the estimation of CSF proteins are not available in lab, then Pandy's test for globulin is performed. In this test, the CSF is added to the saturated solution of the phenol. If cloudiness develops immediately, it indicates presence of increased globulins and the test reported as positive. If no cloudiness develops, then test is referred as negative. The CSF proteins are elevated in increased capillary permeability of blood-brain barrier, that is which is seen in meningitis, and mechanical obstruction to the circulation of the CSF, which is seen in spinal cord tumors, and increased local immunoglobulin production, which is seen in multiple sclerosis, neurosyphilis, subacute sclerosing panencephalitis, and it is also seen in both increased in the capillary permeability and increased local immunoglobulin production, which is seen in the Guillain-Barré syndrome, and also increased in the hemorrhage in the CSF, like in traumatic TAP subarachnoid hemorrhage. Marked elevation, that is more than 500 mg per deciliter, is noted in complete spinal block by tumor, bacterial meningitis and bloody CSF. This table showing increased in the protein levels in the different disorders of the CNS. That is traumatic spinal puncture, where there is increased in the blood CSF permeability, like in arachnoiditis, meningitis, hemorrhage, and endocrine and metabolic disorders. It can be due to drug toxicity like ethanol, phenolthiazines, and phenytoin, and CSF circulation defects like mechanical obstruction by tumor, abscess, etc. And also seen multiple sclerosis, neurosyphilis. Albumin is neither synthesized nor metabolized in CSF. Therefore, increased in CSF albumin or serum albumin ratio indicates increased permeability of the blood-brain barrier. So, immunoglobulin G can be synthesized in the CNS. Therefore, increased in CSF IgG or the serum IgG ratio indicates either increased permeability or increased intrathecal synthesis of the IgG. So increased CSF IgG and albumin indicates local IgG production. Estimation of the glucose in CSF. Normal glucose level is 2/3 of that of the blood glucose level. A sample for blood glucose should be drawn 1 hour before the lumbar puncture for comparison with the CSF glucose. After collection, CSF sample should be immediately processed for the glucose estimation because falsely low result due to glycolysis may occur. The CSF glucose is measured by glucose oxidase method. The normal range is 45 to 80 mg per deciliter. CSF glucose less than 40 is abnormal. Decreased CSF glucose level seen in acute bacterial meningitis, tuberculous meningitis, fungal meningitis, meningeal involvement with a malignant tumor, and hypoglycemia. CSF glucose is normal in viral meningitis. Coming to microbiological examination, a direct wet mount of CSF, it is suspected done in the suspected cases of Cryptococcus, amoebic meningoencephalitis, candida infection, and trypanosomiasis. Gram smear is done in CSF if CSF is turbid and neutrophil count is increased. Zn smear is done in tubercular meningitis if suspected. Latex agglutination test, it is done for the bacterial and cryptococcal antigen detection. And serological test for syphilis, culture for bacteria and mycobacterial tuberculosis, polymerase chain reaction for tuberculosis and viruses. Coming to direct wet mount test of CSF, one drop of CSF deposit is placed on the glass slide and covered with the cover glass and examined under the microscope with reduced illumination. We should observe for the motile trypanosomes and sluggishly moving amoebae. Naegleria fowleri, it is a free-living amoeba in water which enters through the nose and reaches central nervous system. It causes a fatal type of hemorrhagic meningoencephalitis. Candida albicans may be seen in unstained wet mount. It appears as oval budding forms and as pseudohypae. When cryptococcal meningitis is clinically suspected, the wet mount is examined by dark field microscopy. Alternatively, a drop of India ink is added to the drop of sediment on a glass slide. Cover slip is placed and examined under microscope using 40x objective. Cryptococcus neoformans appears as spherical budding yeast forms, which is 2 to 10 micron in diameter and surrounded by a large unstained capsule. Cryptococca can be demonstrated by India ink preparation in 50% cases of cryptococcal meningitis. Coming to Gram smear, this must be done if CSF is purulent and neutrophil count is increased. Gram smear is positive in 80% of untreated cases and 60% partially treated cases of bacterial meningitis. Therefore, absence of bacteria in Gram smear does not rule out the bacterial infection. CSF is centrifuged and a smear of deposit is made on glass slide. The smear is air dried, stained with Gram's method and examined under the oil immersion lens for the bacteria. Bacteria which commonly cause meningitis are meningococci. These are gram-negative diplococci located inside the neutrophils. Pneumococci, these are gram-positive diplococci and these are surrounded by unstained capsule. Haemophilus influenza, these are gram-negative coccobacilli, and E. coli, these are gram-negative rods. So in this table we can see main difference between the bacterial, viral, fungal and tubercular meningitis. So opening pressure is elevated in bacterial meningitis while it is normal in viral, and variable in fungal and tubercular meningitis. Leukocytic count usually more than 1000 per microliter in bacteria, and it is usually less than 100 per microliter in viral meningitis, and it is variable in fungal and tubercular. In bacterial meningitis, mainly neutrophils are seen. In viral, mainly lymphocytes are seen. In fungal and tubercular also, lymphocytes are more. Protein levels, it is mild to moderate increase in the bacterial, and in viral there is a normal to mild increase, while it is increased in both fungal and tubercular meningitis. Glucose levels are usually less than 40 mg per deciliter in bacterial meningitis, while it is normal in viral, and it is decreased in fungal and tubercular. CSF and serum glucose ratio is normal to marked decreased in bacterial, while it is usually normal in viral, and it is low in both fungal and tubercular. Lactic acid levels are mild to moderately increased in bacterial and normal to mild increase in viral, fungal and tubercular meningitis. In this we can see this CSF, which is stained with gram stain, showing gram negative diplococci, which is characteristic of Neisseria meningitidis. Here we can see association between the age and organism causing meningitis. In 0 to 6 months, most common organism causing meningitis is group B streptococci. 6 months to 6 years, Streptococcus pneumonia is most common causative organism, while 6 to 60 years, Neisseria meningitidis is most common organism causing meningitis. Above 60 years, again Streptococcus pneumonia is most common organism. Here some diagrams which are stained with gram stain. In first we can see Neisseria meningitis, gram negative cocci seen inside the neutrophils. Second picture we can see diplococci which are gram positive. These are nothing but Streptococcus pneumonia. And in third one, these are gram negative Haemophilus influenzae. Third test, that is Zn stain for Mycobacterium tuberculosis. In tubercular meningitis, number of tubercle bacilli is usually low in the CSF. So Zn stain or AAP staining is not a very sensitive method for detection of tuberculosis in CSF. AFP smears are negative in about 70% of cases of meningitis. Fluorescent Auromin stain have better sensitivity than the Zn stain. Next test, that is latex agglutination test. This test for bacterial antigens, which these are very sensitive, rapid and simple to perform. Currently available test which can detect Neisseria meningitidis, H. influenza, Streptococcus pneumonia and agalactici. These tests are particularly useful in patients who have been partially treated or in whom gram stain and culture are negative. These tests have largely replaced India Ink preparation for diagnosis of cryptococcal meningitis. Next test is Limulus lysate assay for endotoxin which are produced by gram negative bacteria. The Limulus amoebocyte lysate assay, it is a rapid, sensitive and specific test for the presence of the endotoxins. Endotoxin is produced by gram negative bacteria like Neisseria meningitis, H. influenza, type B, E. coli and Pseudomonas. This test is particularly useful as a rapid test in newborns in whom these infections are common. Next test is serological test mainly done for the syphilis. If fluorescent treponemal antibody with absorption test is positive in serum, venereal disease research laboratory test should be done on the CSF if neurosyphilis is suspected. So VDRL test is highly specific but it lacks sensitivity. Therefore a positive test rules in but does not rules out the diagnosis of neurosyphilis. Combination of positive FTA antibody test in serum and reactive VDRL test in CSF is diagnostic of active neurosyphilis. Next is CSF culture. Culture of CSF is indicated if bacteria are seen on gram-stained smear or leukocytes or proteins are increased. Culture remains the gold standard for diagnosis of bacterial meningitis. For culture, CSF is collected in tube 2 is used. Sensitivity of culture for identification of bacteria is about 90%. In incompletely treated cases, sensitivity is less. So usually CSF sample is inoculated on chocolate or heated blood agar and blood agar. In newborn infants, same sample is also inoculated on McConkey agar. In tubercular meningitis, culture for M. tuberculosis is positive in about 56% of the cases. If larger volume of CSF is used, that is 10 ml, for the inoculation, sensitivity for detection increases. In cryptococcal meningitis, culture positivity rate is 95% of the cases. Next test is polymerase chain reaction. It is highly specific and sensitive tool for the diagnosis of infections of the CNS. It uses probes to detect genes specific for infecting organism. The test is rapid and requires only a small amount of CSF. It is high cost and availability only in a few specialist laboratories are major limitations. CSF PCR is mainly useful for diagnosis of viral infections like herpes simplex, enterovirus, herpes zoster, and tuberculous meningitis. Special investigations like CSF protein electrophoresis. Protein electrophoresis of normal CSF differs from the normal serum in the presence of prominent transthyretin band and an extra transferrin band, which is also called as beta 2 transferrin or tau protein. The protein electrophoresis of CSF is used for identification of oligoclonal plants and to determine whether fluid submitted for examination is CSF or not. So, what are these oligoclonal plants? These are agarose gel electrophoresis of concentrated CSF is used for detection of these oligoclonal bands. These are two or more discrete bands in the gamma region. The presence of oligoclonal bands on CSF protein electrophoresis that are absent on concurrently runs serum protein electrophoresis is indicative of intrathecal synthesis of the immunoglobulins. These bands have been identified in majority of patients with multiple sclerosis. However, they are not specific for this disorder. They are also seen in subacute sclerosing panencephalitis, viral CNS infection, neurosyphilis, and Guillain-Barré syndrome. CSF leakage. Occasionally, clear fluid leaking through the nose or ear after trauma or surgery is submitted for the examination to determine whether it is CSF. Due to the risk of recurrent meningitis, accurate identification of such fluid as CSF is essential. So, recommended test for this purpose is protein electrophoresis with immunofixation for the transferrin. Protein electrophoresis of CSF shows an extra transferrin band that is called as tau protein, which is absent in other fluid and secretions. The tau protein is an enzymatically modified transferrin that moves just behind the unaltered transferrin in beta region. Identification of two isoform bands of transferrin on protein electrophoresis is a highly sensitive and specific test for identification of fluid as CSF. Other body fluids or secretions do not show second isoform band. So in this first photograph, we can see in the serum there is only two bands are there, but in CSF we can see extra two bands in the gamma region, which is seen in case of multiple sclerosis. Second picture, we can see example of tau protein. In first lane, there is normal CSF where two bands are seen. In lane 2, that is of serum, we can see only one band which is of nasal fluid. Lane 3 is nasal fluid showing two bands. One is in the normal place and another one is at the place of a gamma region, which indicates CSF leakage from the nose. These are my references. Thank you.